to the primary care, and they'll admit you into more intense care. So triage is important there at that point, and it depends on both the availability of beds and the availability that were there at the particular time. As the pandemic progressed through Kazakhstan, there were actually more test kits and more opportunities for testing people. So that became less of an issue. But there was always an issue of how many beds do we have available for COVID-19 patients. Surveillance is another problem. We have the official confirmed records, but remember, official confirmed records of cases and deaths are never really truly a reflection of the total numbers. However, they can be used as a means of tracking what might be going on in the country. And then so surveillance was also important in primary care, but it was not the primary concern of primary care or the healthcare facilities because they were overloaded. Their primary goal was to treat people first. Surveillance always came second until you had an easier process until that there was a decline in the number of cases in the pandemic. And education, to educate people so they wouldn't get other people sick. Now, in the educational process, there was also a need for contact investigations to identify those people that might have also gotten sick. Initially, what the primary care did was provide education to let people know if other people are sick and they're seriously sick to come in to go through the process of triage to determine if they had to be admitted into the hospital. However, in the future, we're going to have to rely a lot more on the public health organizations to actually do the contact investigations to identify who the contacts were, because it's much more effective when you can do it in the community itself, and then provide recommendations on what that patient or patients should be doing. Also, there's another issue that is often not mentioned, is providing support and protection for the high-risk groups of healthcare providers who are at high risk because they have such an intensity of exposure. Now, there's a number of biases, which I'll just mention a few of counting cases. We have problems with the number of test kits. Are the numbers being reported correctly? There are many people who do not come into the healthcare facilities. They stay home. Even some of those may die, but many people who have mild cases actually never enter the healthcare system. Counting deaths is also a problem, especially with the excessive pneumonia cases that were not counted initially. And that affects the counts of deaths. So we have a problem trying to count case fatality, the number of deaths per population who have the disease, because we have biases both in the numerator and the denominator. So here we have a series of major lockdowns, an emergency lockdown, quarantine, where people were required to stay home and to have very rigorous quarantine if they had symptoms, and to wear masks, and to deal with the issues of the pandemic at the time. Now, one thing that we learned in our studies is that season matters a little teeny bit. Temperatures matter, but not much. The biggest impacts are the regulations, and which lead to behaviors of personal behaviors and social behaviors, with a median incubation period of about 4. So you can see that there was an increase in the number of tests, COVID-19 tests, over time. So we had more people tested. That will also seem to increase the actual numbers of the COVID-19 patients. And from March 20th to June 21st, we had massive increases in the numbers that were being tested. A government in July 5th, because of an increase, actually decided to lock down on a light lockdown and a soft lockdown on the country, a much softer lockdown, because of a massive increase after people were circulating after the strong lockdown. As you can see, March 16th, there was a state of emergency. March 17th, the end of the state of emergency. Then there was a real increase. Now, this is an increase not only due to real numbers increasing, but also because there was more people being tested. So you see a real increase. So as of July 5th, it was a softer lockdown, and you see the drops. It drops down because of the softer lockdown. The pandemic is being controlled, the spread of disease being better controlled. But then we had a new definition. With a new definition, which increased the numbers of confirmed COVID-19s, we see an increase which isn't real, it's artifactual. So we see a continued decrease in the numbers from that time on. So what we had is that from August 1st, we had a new definition defining that unknown pneumonia cases that had clinical or radiological consistencies with COVID-19 were also counted, even if they were not tested. They were also counted. So that increased the numbers at the end. It gives you a much more accurate number of the more severe cases of Kazakhstan. And just the last moment here to show that this is the number of deaths. We see a drop in the number of deaths. We see an increase in the number of deaths when it's actually not real, because on August 1st, we had an unconfirmed death, pneumonia deaths included as COVID-19 deaths. So we see a continued decline with the softer lockdowns. Now, education is everything. People's behaviors during winter is not the temperature, it's how people behave, how often they're together in households, how often they are in other gatherings. Do they wear masks? Do they have social separation? And many of the other factors that were mentioned in the previous lecture were all essential. But winter affects us in that way. It brings people together. So we don't know exactly what's going to happen. Maybe some increase, but right now there's been a decline in the number of confirmed COVID cases. Thank you very much. And that was the last slide.